Welcome to First Do No Harm with Massachusetts Citizens for Life board member and physician Dr. Mark Rollo. This broadcast will focus on medical ethics from a Catholic perspective and address abortion, physician-assisted suicide, contraception, natural family planning, IVF, healthcare proxy, and other topics. Please be advised that this show may not be appropriate for children under 13.
Hello and welcome back to First Do No Harm, a show about medical ethics from a Catholic perspective. I'm Dr. Mark Rollo. The last show featured part 1 of my interview with Barbara Meier, who is a Creighton model fertility care practitioner and naprotechnology nurse. Today I will play part 2 of that interview. Barbara will relate some fascinating stories regarding her teaching as well as her nursing experience in guiding patients through the naprotechnology treatment of infertility. I will also say more about the ERDs, the ethical and religious directives for Catholic healthcare services, which is a document issued by the United States Conference of Catholic Bishops. Catholic healthcare services, such as Catholic hospitals, are obligated to follow the ERDs. Individual Catholics are also morally obligated to follow these directives, which roughly correspond to the Catechism of the Catholic Church, paragraphs 2258 through 2275. Also, if one considers the meaning of the word Catholic, which means universal, the ERDs are a moral guide to anyone who wishes to behave in a just and righteous way when seeking medical intervention. First, let us begin, as always, with prayer. For as stated by the U.S. Catholic bishops, only with prayer that storms the heavens for justice and mercy, prayer that cleanses our hearts and souls, will the culture of death that surrounds us today be replaced with a culture of life. In this year of St. Joseph, let us pray for a chaste heart like the heart of St. Joseph. Men especially need to seek his intercession to remain chaste outside of marriage and faithful within marriage. Joseph most chaste, pray for us. Joseph most faithful, pray for us. Now, before getting to part 2 of my interview with Barbara Meier, I would like to further discuss the ethical and religious directives for Catholic healthcare services, which can easily be found online. As I mentioned last time, the ERD's document has 6 parts, and today I will again be focusing on part 4, which deals with issues in the care for the beginning of life relative to our recent discussions regarding contraception, abortion, artificial reproductive technologies such as IVF, and natural family planning. Last time I addressed the introductory material, and today I will go over the specific directives, numbers 38 through 54. Number 38. When the marital act of sexual intercourse is not able to attain its procreative purpose, assistance that does not separate the unitive and procreative ends of the act and does not substitute for the marital act itself may be used to help married couples conceive. 39. Those techniques of assisted conception that respect the unitive and procreative meanings of sexual intercourse and do not involve the destruction of human embryos or their deliberate generation in such numbers that it is clearly envisaged that all cannot implant and some are simply being used to maximize the chances of others implanting, may be used as therapies for infertility. Number 40, heterologous fertilization, that is, any technique that achieves conception by use of gametes coming from at least one donor other than the spouses, is prohibited because it is contrary to the covenant of marriage, the unity of the spouses, and the dignity proper to parents and the child. Number 41, homologous artificial fertilization, that is, any technique used to achieve conception using gametes of the two spouses joined in marriage, is prohibited when it separates procreation from the marital act in its unitive significance. For example, any technique used to achieve extracorporeal conception, extracorporeal meaning conception outside the body, as is what happens in vitro fertilization. 42, because the dignity of the child of marriage, and because of the uniqueness of the mother-child relationship, participation in contracts or arrangements for surrogate motherhood is not permitted. Moreover, the commercialization of such surrogacy denigrates the dignity of women, especially the poor. 43. The Catholic healthcare institution that provides treatment for infertility should offer not only technical assistance to infertile couples, but also should help couples pursue other solutions such as counseling or adoption. 44. A Catholic healthcare institution should provide prenatal, obstetric, and postnatal services for mothers and their children in a manner consonant with its mission. 45. Abortion, that is the direct intended termination of pregnancy before viability, or the directly intended destruction of a viable fetus, is never permitted. Every procedure whose sole immediate effect is the termination of pregnancy before viability is an abortion, which, in its moral context, includes the interval between conception and implantation of the embryo. Catholic healthcare institutions are not to provide abortion services, even based upon the principle of material cooperation. In this context, Catholic healthcare institutions need to be concerned about the danger of scandal in any association with abortion providers. 46. Catholic healthcare providers should be ready to offer compassionate physical, psychological, moral, and spiritual care to those persons who have suffered from the trauma of abortion. 47. Operations, treatments, and medications that have as their direct purpose the cure of a proportionately serious pathological condition of a pregnant woman are permitted when they cannot be safely postponed until the unborn child is viable, even if it will result in the death of the unborn child. 48. In case of extrauterine pregnancy, no intervention is morally illicit which constitutes a direct abortion. Now, my interjection is this. The example would be a tubal pregnancy, which may be treated by removing the diseased fallopian tube that's in danger of rupturing, even if that will result in the death of the unborn child. But a direct killing of the unborn child, such as is done when giving a poison like methotrexate to kill the unborn baby in the fallopian tube, that is not permitted, since the direct intent is to kill the unborn child involved in a ectopic pregnancy. Number 50, prenatal diagnosis is permitted when the procedure does not threaten the life or physical integrity of the unborn child or the mother and does not subject them to disproportionate risks. When the diagnosis can provide information to guide preventative care for the mother or pre- or postnatal care for the child, and when parents, or at least the mother, give free and informed consent. Prenatal diagnosis is not permitted when undertaken with the intention of aborting an unborn child with a serious defect. 51. Non-therapeutic experiments on a living embryo or fetus are not permitted even with the consent of the parents. Therapeutic experiments are permitted for a proportionate reason with the free and informed consent of the parents, or if the father cannot be contacted, at least the mother. Medical research that will not harm the life or physical integrity of the unborn child is permitted with parental consent. Number 52, Catholic healthcare institutions may not promote or condone contraceptive practices, but should provide for married couples and the medical staff who counsel them instruction both about the Church's teaching on responsible parenthood and in methods of natural family planning. 53, direct sterilization of either men or women, whether permanent or temporary, is not permitted in a Catholic healthcare institution. Procedures that induce sterility are permitted when their direct effect is the cure or alleviation of a present and serious pathology, and a simpler treatment is not available. Again, my interjection, an example of this would be doing a hysterectomy for uterine cancer, which would obviously also result in sterility. And finally, number 54, Directive 54 of the Ethical and Religious Directives in Part 4 of the document reads, genetic counseling may be provided in order to promote responsible parenthood and to prepare for the proper treatment and care of children with genetic defects, in accordance with Catholic moral teaching and the intrinsic rights and obligations of married couples regarding the transmission of life. Here is part 2 of my interview with Barbara Meier. Do you have 1 or 2 or 3 good stories to tell? Of course, without mentioning names, of course.
Oh, sure. Why not? Well, I mean, every couple's different. Every couple's different.
Yeah.
Some of them are a little skeptical. One of my favorite stories to tell is a couple that came to me. They wanted to learn how to avoid a pregnancy. And I said, great, we can teach you that. And I told them the stats, how effective it is, et cetera. And they said, well, we're still taking the pill. And the husband was very, very nervous about going off the pill.
Yeah.
So he said, can we learn how to chart and then decide whether to go off the pill or not? Because normally the first step is go off the pill, and then your body can start functioning, and we'll see it. And I said, well, I can teach you how to observe. I can show you what's supposed to happen. I can show you what we're looking for and how to document it, and we can give it a try. So they did. And they learned very well, and came to a couple of follow-ups. And when they presented me with their chart, they said, this doesn't look right. What's wrong? And I said, well, what's wrong is that you're telling your ovaries not to work well.
Yeah.
And this is showing us that your ovaries aren't, in fact, working well. just like you asked them not to. So this is what ovarian dysfunction looks like.
Mm-hmm.
And it doesn't look like the nice charts in the book, because that's what you've asked it to do. Now, if you'd like to see what a normal cycle looks like, now you have to go off the pill to see that happen.
Yeah.
And they were considering that last time I saw them. So,
yeah. Well, that was a very good approach. I think a lot of teachers would say, nah, you got to be off it. So when you're ready to come off, come back. But it was
they were
that was
curious.
A good teaching. Yeah. You see, this is how you're making your body diseased in a way. You're making your body not function properly.
Exactly.
And
we showed them that.
Yeah.
So that was interesting.
Yeah.
And another couple that learned that, they went to pre-Cana. They were about to get married. And honestly, that was the first time they were ever told, you shouldn't be having sex with each other.
Mm-hmm.
Until the wedding. They really, really did not know that. So they looked at each other and said, well, all right, then we need to stop. And I give them a lot of credit for that, because that's a very difficult decision to make.
Yeah.
And they did. I think they had about 6 months till the wedding. She had an implant on in, so she made an appointment, had that removed, and came to me.
Wow.
And they were rewarded with 6 months of continuous cervical mucus discharge. So I thought, great, this is going to be a challenge. That is my most challenging situation, where it's just continuous mucus. And you can work with a couple, and we can figure out the patterns and identify days, even though there's mucus present, that would not indicate fertility, and we were working towards that when their wedding day arrived. And I don't know if you remember this, Doc, but we actually did a family planning progesterone level the day before their wedding.
Yeah.
Because we weren't quite there yet with identifying the patterns, and they're getting married tomorrow, so they just wanted to know, are we fertile or not?
Right.
And we were able to tell them.
Yeah, that's one of the interesting parts of the practice. Of course, what Barbara's talking about is that if you're having mucus all the time, you can't easily tell if you're fertile or not. You can, but it takes a lot of instruction. Mm-hmm. And but the beautiful thing is that once you identify by the mucus observations what the probable day of ovulation is, you can remove any kind of uneasiness or uncertainty just by doing a blood test. Mm-hmm. So that's just one of the many benefits of using the method. Any other stories come to mind?
The end of that story actually is when they came back from the honeymoon. She showed me your chart, and there were 5 dry days, which we had never seen any dry days.
Huh.
And she pointed to that and said to me, "This is proof that God exists."
Well, it reminds me of another proof that God exists, and that was a couple that we worked with together. Mm-hmm. And I wish we could say we were responsible for this, but this is where all the credit goes to God. Well, it always does anyway. But
I know.
Do you know what I'm talking about?
Yes, absolutely.
Well, this was a couple who had been infertile, had problems with infertility for a long time, and I don't remember all the specifics. But
amenorrhea.
That's right. Yes, she when initially she presented, she hadn't had a period in I don't know how many months. Mm-hmm. And she was not. She was in her 30s, right, Barbara? Mm-hmm. Mm-hmm. And so she was not a spring chicken. Although, because when you get into your 30s, especially mid to late 30s, you're sort of considered old, which offends a lot of women.
But as far as fertility goes, that's correct.
Yeah,
it really drops through your 30s like crazy.
That's
Nobody
right.
tells you that.
Yeah, and a lot of women need to know that, because a lot of them come, they're approaching 40 and they wonder why they're not getting pregnant. But anyway, this woman wasn't getting pregnant. She wasn't even having a period. So I said to her, and you remember her well because you were looking at her chart, and we said, well, first of all, we got to get you to start your period. So here, take this progesterone for 10 days, and it should bring on a period. And then we'll try to figure out what's going on with your body and with your ovarian function. So sure enough, she took the progesterone for 10 days, and she still didn't have her period. So we were thinking, well, gee, what's going on with that? So we said, well, just to make sure, we ought to do a pregnancy test. And sure enough, She was pregnant with not one, not two, but three. She had triplets. And it was a very humbling experience because I had nothing to do with it.
Absolutely. You didn't. Well, you had prescribed some medication that would be likely to do that, but she hadn't taken it. I remember that. And this is another good point. The fact that she had triplets was just so astonishing in all the years looking back at your practice and Dr. Carpenter's practice. This was the only triplet pregnancy.
Yeah, amazing.
In 30 years.
Oh,
so,
and now that you mention that, had I given her some medication to induce ovulation, but she didn't take it?
Correct. You said, well, when your period starts, then you take it.
Oh, okay, that's right.
But
I forgot.
She never got a period, so she never took it.
In fact, she went to see an OBGYN. You know, I wasn't delivering babies anymore at that point, so I referred her. And she said how her obstetrician sort of was upset because I must have given her fertility drugs.
Well, unless you consider progesterone.
Yeah, well, she figured I had given her something more potent, which of course I didn't. But anyway, that was those triplets I think are about 6 or 7 years old.
Yeah, wonderful. That's great. That turned out really well.
Yep.
That was all God, though. We couldn't take any credit for that one.
Yeah, that's right. We had another one comes to mind that we did kind of work together with, and that was a woman who had an ectopic pregnancy, and then she wasn't getting pregnant, and she took a pill that's called letrozole. And that did induce pregnancy. And after several cycles, I forget how many, she was able to achieve pregnancy. But after that successful pregnancy, she wanted to have another. And then we had to bring out the big guns, which are injectable medications. And you have to follow the follicle development on the ovary with ultrasound, which we did, and that was very time intensive. And what are your memories about that case, if you can recall, Barbara?
Well, sure. Well, we didn't do a lot of follicular ultrasounds back then. We were just starting to get into that. Now It's very common.
Yeah.
And I think we were limited by finding facilities in the area that would be able to do that. But it's important to follow with the ultrasound because if you're giving the injectable medications, you could easily get, 3 mature follicles, and you were talking triplets and quadruplets and things like that. So for the restorative reproductive medicine, like NAPR technology, we would be instructing the couples, hey, we might want to avoid trying to achieve in this cycle because we just got too much of a response from the medication, and we don't really want a multiple pregnancy. That's very dangerous. So that's one of the reasons that we don't have a lot of triplets and twins and things like that, multiple pregnancies.
Right.
Yeah, so that went really well.
And since you mentioned that, and she ultimately was able to achieve pregnancy, and interestingly, when we looked at the follicle, it didn't appear as though there was an egg in that follicle, but sure enough, there was, because she...
Oh, yes.
Remember that? And so... Wow. Yeah, and you mentioned restorative reproductive technology, or reproductive medicine, because the artificial reproductive medicine, such as IVF, they would, we tried hard not to have multiple pregnancies, whereas IVF does that on purpose. They fertilize multiple eggs, and sometimes they implant multiple eggs, and if they do get a multiple pregnancy, they do what's called selective reduction. So they abort one or more of the fetuses. So obviously that's very unethical and very destructive, and
distressing to the mother. Here's a couple that desperately wants to have children, and now they're told you should reduce the number of children that you have currently. That's terrible,
Yeah.
terrible medicine, in my opinion.
Oh, absolutely. Not to mention the fact that when eggs are fertilized and not even implanted, they're just thrown away or frozen, and these are tiny human beings. We all started out that way. In the few minutes we have left, I wonder if you had anything else you wanted to say, or any other favorite stories you might have.
I had another patient I was taking care of here, teaching her to chart. She was single and had hormone difficulties. Her charts were a mess. She was learning to chart so she could get help with her irregular cycles. It turned out it was polycystic ovary, and really pretty bad. She was in a bad way. So we were working with her, and her cycles eventually straightened out. But when she came to learn how to chart, she showed up and said, "Can my boyfriend listen?" And I said, "What?" I was teasing her. I said, "Well, I don't know. Is he a keeper? Because, we talk about some personal stuff here,
Yeah.
And she was flustered, and she says, "Oh, well, I think so." And so, of course, he's welcome. So, of course, he came in and learned with her. And follow-up visit was scheduled for 2 weeks later, and she came back. She was wearing a diamond.
Oh, wow.
And he said, "It wasn't until that moment that I knew that she would say yes."
Yeah. Yeah, so you helped along the commitment there.
Exactly. Well, yeah, I think he was ready, but he didn't know that she would say yes. And so by the time they got married, her cycles were all straightened out, and they didn't have to deal with infertility or anything. They achieved their first cycle of trying, and they now have a wonderful son. But we were able to see the signs in her chart, like, hey, this is really messed up. We have to help your body to work better. And so she was able to actually get that taken care of before they started trying to achieve a pregnancy, before they had a miscarriage or 2 or 3.
Well, that's a happy way to end our conversation, and thank you, Barbara. This concludes my interview with Barbara Meier. Next time, I will interview Dr. Paul Carpentier, with whom Barbara is currently collaborating at the Gianna Center on Long Island. Dr. Carpentier and I will delve deeper into the truly incredible breakthroughs of NAPRO technology, natural procreative technology. To find an instructor near you, again, go to fertilitycare.org, and to learn more about the amazing medical applications of the fertility care system, go to naprotechnology.com. Until next time, remember, we should always treat life with care and respect. And at the very least, we should first do no harm.
Thank you for tuning in to First Do No Harm. Dr. Rollo welcomes your questions and comments. You may contact him at markrollo978@gmail.com. That's MARKROLLO978@gmail.com. Thank you, and until next week, remember, first do no harm.